It has a fibrovascular core, the surface of which is lined by cells which have elongated to oval nuclei which are clear, and many have nuclear grooves in them, and minimal pleomorphism apart from piling up, crowding, eggs in a basket appearance. In the next slide we see them much better, and we see that there are some hobnailing seen at some places, but otherwise it's a classic nicotine slide of a papillary carcinoma of the thyroid. This is another field to show the same. The core shows a few lymphocytes and some blood vessels. So with this picture, there was no doubt that this was a papillary carcinoma, and the only issue was there was no normal thyroid tissue seen in this slide. And what is seen on whatever that caught my eye was this surface or some kind of an epithelial lining. And that is what we see here, which is seemed to be lined by some epithelium, squamous epithelium. I said, okay, if this papillary carcinoma of the thyroid, where does this epithelium comes from? So my thoughts went on to whether it's from a thyroglossal cyst, arising from a thyroglossal cyst. So this was a pseudo-stratified surface epithelial lining, and this was the lesion arising from it. Better seen in this section, and we see that this tumor is in continuation with the surface epithelium. And this section highlights the papillary configuration. Definitely the lesion looks polypoid. So went back to ask the surgeon, where is this biopsy from, and exactly from which part of the thyroid? But to my surprise, he said this was from a nasopharynx, and it was a polypoid lesion protruding into the nasopharynx. And these were the images to show the same. So a biopsy was taken from this part of the tumor. So here we have a papillary carcinoma of the thyroid, but the question is it metastatic, or is it arising from the so-called ectopic thyroid if that is primary? And what is the thyroid status in this child? And now we have origin, this is from nasopharynx. So this was very puzzling. Going back to the slide, this shows that some of these spaces so-called contain basophilic material. Somewhere, of course, eosinophilic. There was little bit of calcification, but true, no Samoma bodies were seen. No normal thyroid tissue was observed. My eyes went on the surface epithelium and the tumor in relation to it. And we could see that this was pseudo-stratified, which you would definitely get in a thyroglossal duct cyst, but this is from nasopharynx. So could this be the nasopharyngeal or the respiratory type of epithelium that one sees? So let's compare the slide with a classical papillary CA thyroid. So this is the present case that we have, and here is the classical papillary CA from the thyroid in front of the neck. There is no difference except that the nuclei of the papillary CA thyroid here are oval, rather oval, and here they seem to be little elongated and jam-packed. So we have a papillary carcinoma thyroid with the queries whether it's from the ectopic thyroid, it is metastatic, or if so, where is the primary? And the thyroid status was proved in this child to be normal. Thyroid function tests were normal. And what about the markers? I said, let us see. Just first to start was a CK, which is diffusely positive, lining the surface epithelium as well. And this is the CK7, which proves the tumor to be strongly positive, whereas the surface epithelium is negative. So CK7 going towards thyroid in this region. TTF1 nuclear stain strongly positive in the tumor. Note that the surface epithelium is negative. And this is in another area where the tumor is positive for TTF1, diffuse but weak. So with this, to recollect, where could ectopic thyroids be? Starting from lingual thyroid going down up to the retrosternal area in this tract. And whether are we dealing with the lesion arising in this region of the lingual nasopharyngeal area? A bit far-fetched. But again, we go back to the routine exercise of primary, secondary, where the ectopic and thyroid was normal in this child. So we said, let's do the thyroglobulin test. This is from a papillary CA. Thyroid shows diffuse, strong cytoplasmic staining. And in comparison, we have the tumor, which is negative for thyroglobulin. So the diagnosis of so-called ectopic nasopharyngeal thyroid papillary carcinoma is out in this child, and we come to a lookalike tumor, which is the primary thyroid-like low-grade nasopharyngeal papillary adenocarcinoma. For short, it is called TL-LGNPPA, a long short form. So the case 1 diagnosis is primary thyroid-like nasopharyngeal papillary adenoCA, looking exactly like papillary carcinoma, classical papillary CA of thyroid. So how do we differentiate? You see, the markers are all similar, and except for thyroglobulin, which is the only marker which differentiates. Of course, by the end of this exercise, we would have ruled out metastasis from liver and lung, which could also throw up metastasis like papillary CA. The other point to note is when we have papillary thyroid carcinoma, classical, we know that these tumors are rare in pediatric age group, have a wonderful or a favorable, excellent prognosis, and the 10-year survival is much more than 90%, whereas the low-grade nasopharyngeal papillary is a very rare, extremely rare malignant tumor, but it can land upon your table at any time. And so far, 16 cases have been described, and they range from 9 to 68 years of age group, so they could affect anybody, and that treatment is complete surgical excision, just like the conventional papillary thyroid carcinoma. But unfortunately, being in the nasopharynx, they cannot be cleared, completely cleared with surgery, and that radiotherapy has to be used as adjuvant chemo, adjuvant therapy, and that is the difference here. And these tumors keep recurring, and they can turn low grade to high grade. Now going over to case number 2, lytic lesion in the mandibles in 6 months. So this is a 40-year-old female who had this lesion in the mandible of 6 months duration, and this is the section from the same which shows that this is the normal bone with the skeletal muscle attached to it, and here we have a very cellular lesion arranged in with cells arranged in sheets. Probably here they look as if they are in a glandular pattern with very thin septae which are intervening, and these cells, they're very cellular. I mean, the neoplasm is very cellular, but they have very distinct clear cytoplasm. The nuclei are vesicular, they are small in comparison to the amount of cytoplasm, which is so empty looking. So exactly clear cell, and these are the thin septae which seem to be hyalinized. They are highly vascular. You see the thin sinusoids intercepting between them. So going higher above, yes, look very monotonous. The nucleoli are not seen. So what do we have? Is this a metastatic lesion? Epithelial, so it's a metastatic carcinoma. But looking through diagnosis that could one think of with clear cells, tumor, malignant, in the bone, say in the head and neck region, are the starting from mucoepidermoid going up to the clear cell variant of malignant melanoma. So the way to go about probably, yes, we start with the immunohistochemistry. The CK is positive in this case, which is not very strong, but does say that many of the clear cells are still empty. They are not stained. Vimentin is positive but weak. But CD10 is positive because one thought that crossed my mind at that moment is it metastatic from the kidney, CD10 being positive? So the diagnosis further to take it on with the renal cell marker, which is negative. HMB45 is negative. So what were we dealing with in this head and neck region in the mandible? Could it be myoepithelial versus metastatic renal cell carcinoma with CD10 being positive? We did other markers and this is how it fit, CK, EMA, Vimentin, S100, GFAP, calpanin, they were all positive in this case. Even the calpanin was positive, whereas this tumor was negative for PSA, TTF1, napsin A, and PAX8. So here is the calpanin staining to show how strong is the cytoplasmic one in this tumor. So with the clear cell variant of a carcinoma within the mandible giving rise to an osteolytic lesion, we went on to say that it is probably an intraosseous clear cell variant of a myoepithelial carcinoma because there was no other lesion elsewhere. Kidney was perfectly normal. So in referring to this article, Clear Cell Entities of the Head and Neck, a select review by NAIF, there is a paragraph which talks about how one could get intraosseous salivary gland tumors and that they could derive from ectopic salivary tissue, may arise from the neoplastic transformation of the mucous cells found in the lining of the small dentigerous cyst or from embryonic remnants within the mandible. So we hope, and so far followed up for 3 months, this patient is doing well, and we assume that that was a primary intraosseous myoepithelial carcinoma involving the mandible. We go on to this next case, which is 28 years old. We came with the space-occupying lesion in the upper end of the femur. This was osteodense lesion, and as it is clear from the biopsy, it is very it is cellular but has lot of bone, has bit of cartilage. He's an young man, he's 28 years old, he's a male. And going higher on this biopsy, we see that you have the trabecular bone going towards the lesion, to the center of the lesion. Higher magnification shows that these bony trabeculae are well lined by the so-called probably osteoblasts, and they're very prominently seen. They seem to be producing a lot of osteoid, which is maturing to form ovum as well as lamella places. So this is how they are placed, very prominent lining of these trabeculae. So this is a male with a lesion right in the metaphyseal, epimetaphyseal junction. And this is how the cells which seem to be sitting on top of these bony trabeculae. So these are the sections. Some are exfoliated, which is a bit unusual in this case. Some of them do not have, as seen here, no bone, but they are only cellular with those cells covering on those finger-like projections. This is another area where we see a little bit of the osteoid, the oven bone being formed. And this is the area at the periphery with periosteum. The cells seem to be infiltrating through the periosteum going out. So it gives an appearance, yes, it's an infiltrating edge. Here we have a little bit of cartilage, the bone being formed, oven bone, yes. So the diagnosis is an osteoid producing malignant neoplasm. So is it primary, is it an osteosarcoma, or is it metastatic? That's one thing we should always keep in the back of our mind. So the first job is to prove that this is primary osteosarcoma. But this patient has no other lesion anywhere else in the body. There is nothing else to take us forward in this case. So went back to this case to see that some of the cells are very pleomorphic and they seem to be like a fibrovascular core, something like papilloid fashion. So is it epithelial? Was the feeling that came to your mind amidst so much of bone being produced by this tumor. We did a CK and that CK7 is strongly positive in these tumor cells, and it was also positive for napsin A. This is the higher part showing the cytoplasmic staining, and TTF1 was however negative. So it's an osteoid producing malignant neoplasm for sure, and that napsin A being positive, it is a metastatic adenocarcinoma from the lung, looking so much like that of a primary osteosarcoma. So we move on to another case, a case for opinion. It was a slide from a 52-year-old female. It was a lung biopsy. The patient has a big patch in the right upper lobe, and the true biopsies were sent. This scores show peripheral lung tissue where the alveoli are separated by thick alveolar septae, which are thinned out. There are solid areas. Going higher on to this aspect, we find that many of the alveoli contain eosinophilic material, but it doesn't look like lung, it looks very solid. You have fibroblastic proliferation with epithelialization at the periphery, this granulation tissue, there's some edema. Going higher on to this, there's some bit of hemorrhage, there's lot of inflammation. So it looks like an inflammatory lesion in a patient who was suspected to have mass in the lung. So there's another view of the same, this is the respiratory epithelium. So there's inflammation, there is this fibroblastic proliferation. So it looks like an interstitial pneumonia with this fibroblastic foci from the granulation tissue being settling down to healing. So we said, let's have a second biopsy if you're really thinking of, because the first biopsy didn't hit your tumor. So they went ahead to do another biopsy, and that showed similar features. More of those fibroblastic foci. The alveolar septa are better, they are thinned out, but there is still a lot of edema and thickening of the peripheral lung tissue. So we said there is no tumor again. So, but we seen that there was a patient has no diagnosis. So they went on to do a third biopsy, and the third biopsy showed small cores of this tissue which were highly necrotic. So we knew that we were dealing with the tumor. These with small cellular foci, which on higher power showed them to be epithelial in nature. They're multi-layered. This is how they seem to be um, arranged in sheets, and CK7 was positive, proved it to be epithelial. Ki was very high. The IHC markers that panel was done, it was negative for 20 TTF1 napsini and CD, any of the fiber 6. So all markers were negative except for CK7. In this patient, who was a female, elderly, so we could just say it was a non-small cell carcinoma undifferentiated. But then we said there's something wrong in this patient. Yes, let's call networking, talking to the physician made a lot of difference here. He said no, the third biopsy was not from the lung. So we said, you said repeat biopsy, repeat 2 biopsies have come. We thought, we assumed that the third biopsy is also from the lung. He said no. The patient is said to have a retroperitoneal 2x2 mass, and that was a true cut biopsy from there. And going probing further, the patient was being treated or treated earlier for endometrial adenocarcinoma. And here we have Vimentin positive and PAX8 positive. So the so-called tumor core biopsy that was assumed to be from the lung was not from the lung but from the retroperitoneum, and proving that this was a metastatic endometrial carcinoma biopsy retroperitoneal mass lesion. So we need to, what is the highlight of from this case is that we need to know first where is the biopsy from. It is true that the request form give us some details, but not all the time they're true because they're written by some of the assistants and not correct. So let's go on to case number 5, which is from a 22-year-old male who presented with a shoulder mass of 6 months. Clinical diagnosis or radiological diagnosis was aneurysmal bone cyst. And they also thought, could that be a giant cell tumor? So curettings were sent, and this is what it showed. These are the nodular masses, which are cellular, but they have pale areas in which are the cells which are trapped. And going closer, you realize that these are all the cartilaginous matrix or myxoid matrix, or maybe myxoid or chondroid, in which you have your cells which are trapped, and there is some focus of calcification. These are more cellular areas of the lesion. There is calcification at its base, and here we have some giant cell amidst the cellular foci. So going closer to these cells, they seem large, polygonal. They have a vesicular nucleus. Some of them are round, some of them are oval, some are polygonal in shape, some are elongated, and they seem to have grooves there. Here we have giant cells, and here are blood spaces. So, okay, their diagnosis was ABC. But then, would this histology fit an aneurysmal bone cyst? There are many giant cells in addition. There is calcification, there is ossification that's happening, and you have spaces, you have this chondroid matrix. So here we have large areas of hemorrhage and the tumor with many giant cells. There is bone, small and large areas. And we have the trabecular bone in these septae, which are traversed by these blood spaces. So you have cartilaginous or so-called matrix. So it seems to be a very cellular lesion with 3 components. It has a chondroid matrix with those cells which are large. You have giant cell component where the giant cells are not regularly placed but concentrated, lining some spaces. And the third component is the space. Okay, clinical radiological diagnosis supposed to be APC, but I said I need the X-rays. They took some time to give it to me. And here a higher part of the same, and here we have the giant cells very prominently seen. More areas, very cellular tumor, and here the cells do look very sort of marked variation in size and shape, okay, but caught in the chondroid matrix. So in this 22-year-old male with a presumptive diagnosis as benign chondroid lesion, we said, and a radiological diagnosis of giant cell tumor in the ABC. Histology with some of them cells showing a grooving, some of them so cellular, variable amount of calcification was prompting a diagnosis of a chondroblastoma. That is what you would expect in this age group of 22-year-old. Can this be a chondrosarcoma? That's another question to answer. Let's look at the images which landed up in time. By the time the images come, as is the regular habit, we look at the slides first without getting carried away, but what is written on the request form, not to get biased with anything. So with the images that have come, this is how it is. So we have a expansile lesion in the upper part of the humerus, which is involving the epiphysis. There is no definite margin. It seemed to extend down into the shaft. There is no soft tissue component. Periosteum is intact. So with a lesion which is lytic, which is situated in the upper part involving the epiphysis. So a giant cell tumor, could it be? Yes, it could be, but the histology doesn't favor a giant cell tumor where you would look at giant cells regularly spaced in the entire section, but it is not. Can this be an aneurysmal bone cyst? But the location, no, because aneurysmal bone cysts are more often in the diaphysis. What about the chondroblastoma? It could be, but there is no calcification, that's not seen here. So we went on to look at the other images. And here they are. We have large cystic spaces and involving the entire head of the humerus. And we see that with contrast, they are filled with material. There is a fluid level, so indicating, yes, there is an APC component in this tumor. So going further looking at, here is one fragment which looks probably lining a cavity with numerous giant cells. More of this bone septae in midst of these vascular channels. We have the chondroid matrix where the chondroid cells, where they are polygonal and some of them elongated, and many have an insignificant or not a very obvious cleaved nucleus. Here the cleaving is very well seen in this slide. In this area there's one more here, there's one more, there's one more. So we have a chondroblastoma, we have a component of an ABC, but it is not definite, it is not a giant cell tumor. And the osteoclasts are part of the ABC, which seem to be lining these spaces and having this giant cell component. So this is the solid area where one could even see some osteoid being produced. So these are the other areas of the tumor where the vascular channels are highlighted, but some of them are lined by endothelial, but not all show the lining. CD68 highlights these spaces very well. You see that these are the spaces which, going higher, you see that they are lined by this multinucleate giant cells. And we have those giant cells beautifully stained for 68. What about the other cells? To prove that they are, we did an S100 to show the chondroblastic origin. And this the nodule with the chondroid matrix and is strongly positive for its time. So this highlights the nuclear grooving. So finally what we have is a chondroblastoma with secondary ABC. So what is the take-home message from this case is that you need your x-rays all the time, even though your histology could be very simple, but you need to correlate with images at all times and discuss the case with the clinician on the other side. We have the case 6. This case turned up a few days ago. This is from a 16-year-old child who complained of swelling around the knee joint since 3 months. So the lesion, which is involving the upper part of the tibia, including the epiphysis as well as part of the metaphysis. So it's a huge lesion with a soft tissue component. So we do not know whether it started from the epi and went down or from the shaft went towards the epiphysis. And what we see here are lobules of neoplasm which show calcification, and you have lighter stained areas which on higher power show that there is chondroid differentiation. There is a fibroblastic component. You have thin vascular channels amidst these tumor cells. And here we see that there is eosinophilic material in the midst of these tumor cells, and these are lined by the tumor, so it proves that this is a tumor osteoid. We have bone, oven bone being formed. These are the vascular channels, more of the osteoid, better seen in this section. And we have this tumor permeating through the periosteum, going out to the periphery. So we have in this case a malignant tumor which is producing cartilage, which is producing bone. So is it a chondrosarcoma or is it an osteosarcoma? Is that important to differentiate? Let us see. So would IHC be helpful in this chart, in this case? And what marker would you do if it is osteosarcoma? For chondro, we know it is S100. We have a chondroid component. I'm sure that would get stained. But what about the osteo? So a lot has been talked about SAT-B2 staining, but we realize that SAT-B2 for a conventional osteosarcoma, the nuclear stains beautifully positive, whereas small cell osteosarcoma where the nucleus also gets in. So it's a very good marker to pick up the the cells, the malignant cells in osteosarcoma. But one should realize that even in chondrosarcoma, we could have staining of SAT-B2. So grade 2 and grade 3 chondrosarcomas are positive with SAT-B2. So in this tumor, in this case, we cannot differentiate with SAT-B2, osteo or chondrosarcoma. And in the paper, as detailed out for the SAT-B2 immunohistochemical expression, is that the chondroplastic and parosteal are 100% positive with SAT-B2, whereas the chondrosarcomas of grade 2 and 3 are positive. So higher the grade, SAT-B2 is helpful, but in grade 1 it is negative. It's positive only in 8% of the cases. So even EMA staining, if done so, could be positive. So there seems to be always a crosstalk between the neoplastic cells and the stroma, and these markers are not truly helpful. But one thing to say, by the dictum that is always taught to us that this case is not a chondrosarcoma, because chondrosarcomas are the sarcomas which affect the older age group, number one. Number two is that osseous malignant chondroid neoplasms in children and young adults, they always represent a chondroblastic osteosarcomas, even when the intratumoral osteoid matrix may be very small. So we go by the statement and by the other features that it is a chondroblastic osteosarcoma. And the highlight of this case is that osteosarcoma can produce osteoid, which we always think, and it is so for a conventional, but it can also produce cartilage as seen in this case, and called as the chondroblastic osteosarcoma, to be differentiated from the chondrosarcomas and malignant. And it can also produce fibrous tissue, that's the variant of osteosarcoma, but they behave comparably. So how not to get tubed? A must in our day-to-day practices, the patient's clinical data correlated with X-ray, and a heart-to-talk with your colleague. And that behind every image, there is a patient. So if you know that there's a patient behind every image, and that is what comes to your mind, and I'm sure you would go all out to do your best. So a networking is very important. It should be a clinician, a pathologist, and we play a bigger role turning the wheels for all three of us, and the radiologists in the present scenarios are truly helpful. So it would help us to put all jigsaw puzzles together to make a composite puzzle, as in this case and in our routine cases as we report. So thank you very much for being with me all through the 1 hour, and hope you enjoyed the cases and the challenges that we face when we look at these tumor alike and masqueraders. Thank you very much.
Thank you, ma'am, for the insightful presentation. I'm sure everybody online has learned a lot. If you have any questions, you may post them in the comment section so that we can take them. Okay. If there are no questions, then we will end the seminar. Thank you, ma'am, for the beautiful presentation. The next webinar will be broadcast live on 11th of April 2020. That will again be a second Saturday of April and at 11 a.m. The presentation will be on the topic Approach to Crescentic Glomerulonephritis by Dr. Mahesh Kunti, consultant nephropathologist at Manipal Hospital, Bangalore. Join us for that.